A degree from Stonehill College and Northeastern University, and has been instrumental, I think, in changing the processes, protocols, and things like from that. He also holds a degree from Stonehill College and also a certificate in advanced statistical process control from Worcester Polytechnic Institute. So I will hand over the podium to Ms. Elizabeth, and we'll just wait for Dr. Brian. Probably he'll join later. And he has been also leading the project and a strong member of the team. So, Elizabeth, over to you now.
Thank you very much, Deepinder. Hello and welcome. My name is Elizabeth Ziemba, and along with my colleagues, Dr. Brian Jack and Mr. Irving Stackpole, we're the founders of Project Red Solutions. We're pleased to present this webinar focused on the best practices for transitions of care, which have grown out of Project Red, re-engineered discharges. Before we start, of course, I'd like to thank Mr. Deepinder for inviting us, and yes, our colleague Liz Clark for making this introduction. We are all connected in this small world of healthcare. So here's what we have planned for you during the next hour. Irving will deliver a 45-minute presentation and then followed by a 15-minute question and answer session with Dr. Brian Jack. A special shout out to Brian, where he's joining us from Boston, where it's 5 o'clock in the morning. Your questions can be typed into the Q&A box at any time during the session, and we look forward to seeing what questions you have for us. So thank you for joining, and Irving, please begin the presentation.
Well, thank you, Elizabeth, and thank you, Deepinder. I want to make sure that everyone can see my screen okay. You can see the initial slide. Great. So it's indeed a pleasure and honor to be here. And what we've done is we've prepared basically a simple agenda. We're going to look at the evidence base and the concepts behind Project Red, which of course stands for re-engineered discharge. We're going to look at the measurable changes that the interventions associated with Project Red can produce in not only in hospital discharges, but in transitions of care in general. We're going to look specifically and individually at the Project Red transition checklist. This is a checklist similar to a pre-flight checklist that an airplane pilot would use. And through Dr. Jack's work with the American Health Research and Quality Institute, this standardized list of transition of care principles will have an enormous impact on outcomes and overall quality. Then we'll talk briefly about implementation, what we've learned about implementation, and basically how to get started if indeed you choose to. So the first question is, why focus on hospital readmissions? Why the focus on these? Interestingly, there's some very good research done in the GCC, in the Middle East, about this topic, and it's recognized widely that hospital readmissions may be the result of a clinical change in the patient. It could be the result of incomplete initial treatment or inappropriate or poor quality treatment. Alternatively, unnecessary or inappropriate hospital readmissions may be the result of the individual, the consumer, the patient, having poor or inadequate engagement in his or her care, not understanding basically that if it's a COPD patient, he can't go back home and start smoking again. The second or other issue could be systems issues. And for a meeting with quality improvement experts, I believe that this will be of greatest interest. What are the systems-based, evidence-based issues, the procedural and process errors that have been shown to result in unnecessary, untoward, and inappropriate hospital readmissions? And then, of course, unnecessary readmissions are indeed a problem. recognized widely to put the patient at risk, to put the providers at risk, and to waste precious resources. And we'll talk further about each of these principles when we review the Project Red checklist. So let's look at the evidence base. Let's look at the hard data that shows that readmissions are a problem and that simple interventions can remediate or ameliorate or reduce those problems. Well, the research shows that there are huge gaps at the time of discharge from the hospital. Research in the United States shows that almost a third of the patients, 27%, receive no verbal instructions about new medications or changes in their medication regimen at the time of discharge. 48%, almost half of the patients, were not told the reasons for the follow-up appointments that he or she were scheduled for at the time of discharge. And as our colleague and mentor, Brian Jack, likes to say, if somebody is sick enough to get into the hospital, they're sick enough to need care after the hospital. So almost a half of the people being discharged were not told the reason for the follow-up appointments. Over half, 55%, were not given instructions on post-hospital self-management. What do they need to do to manage their wound if they've had a surgery? What do they need to do to manage their heart disease if they have heart disease?